So this is a metaphor we use in the pain clinic a lot. The idea of a malfunctioning alarm system, and the house alarm or the fire alarm is a good example. I joke with my colleagues that we're alarm specialists, but actually we are. We work with people whose alarms are malfunctioning. If your house alarm goes off and there's no burglar, it still sounds the same as if there was a burglar. You have a fire drill at work or at school or wherever you were, the alarm sounds exactly the same if there's a fire or no fire. And that's where the confusion lies for our patients. And so the way that we sort of start to explain it is it's like a false alarm. The alarm sounds exactly the same. No wonder they think it's their endo if they've had endo in the past and it feels the same. No wonder they think it's the same problem because the alarm sounds exactly the same. But it's a faulty alarm system. It's malfunctioning. And that kind of analogy tends to really connect with people. They understand what we're talking about then. Would you add anything to that?
Yeah, I mean, it is really a useful analogy because I don't know if we've got our further slides to develop this, but all pain is an output of the brain, right? So that's why we use the term nociception. So Sherrington in 1910 discovered these receptors, mechanical, chemical, thermal receptors, and so the process there is the detection of a noxious stimulus. And when you haven't got that noxious stimulus, then that's the malfunctioning alarm. But the alarm is ringing, it's real. And people really get that. They can really see the distinction. And so it's really a useful metaphor. Yeah, so we pretty much talked about a lot of this. One of the ways to think of it is that while the original problem was required to set off acute pain, healing takes place. And we know that two people can fracture an ankle and one doesn't develop chronic pain, one does. Two people can have a mastectomy. One develops chronic pain, one doesn't. Two people have back injuries. One doesn't develop chronic pain, one does. So we need to explain why that person has developed chronic pain. So it's not to do that, we assume that the tissues have healed in most of the time, and specialists can tell us that they have. And so moving away from the periphery and the fixation of the tissues, we then say it's more to do with that sensitivity of the nervous system. So you've lost your thresholds, the inhibitory descending system isn't perhaps working as well in that particular person. There's evidence for that. And so the electrical signals are going to the brain just too easily. And the important thing now is that normal movements and non-damaging stimuli set it off. And it's so obvious, you examine somebody who's got chronic back pain and you say to them, please touch your toes, and they go like this, just the slightest movement, and so and when you point it out to them that just the slightest thing is really setting it off, they can really relate to it. And then because of the neural plasticity, everything's becoming more efficient, and so everything's been wound up, and the brain wants to know why haven't you removed that 6-inch nail? Why hasn't this gone away? And so all those normal physiological things that happen, whether it's a dog or a human, those physiological things happen, and it all increases. And then the normal protective effects that occur in acute pain, withdrawing, not moving, crying for help, fear of further movement, fear of damage, fear of the threat of that 6-inch nail, just expand.
Patients really connect with the idea that their brain is protecting them by making pain. They really like that idea, and One of the video links that we'll give you today, some of you will have seen it. It's an online resource, 5 minutes to explain pain. Has anyone seen that? It's a pictorial thing. It's Australian, and one of the last lines in that video is so that the brain no longer needs to protect you with pain by making pain. So I guess one of the ways that we describe that, and we'll touch on that later today, is that what we have to do is show the brain that it's safe. So rather than waiting for the pain to reduce and then doing, what we have to teach patients is it's through doing that we show the brain that it's safe, and then it no longer protects so much by making pain.
The one slide we don't have here is a slide we usually show people. It's a tremendously complicated slide. It's by a biochemist called Rohini Kuna, and it's mechanisms of peripheral sensitization. And so it shows all the biochemical we call them little switch-ons to upregulate, and it's extremely complex, and there are multiple, but we're kind of leaving out that physiology. So this is a simple slide we use just to explain the nervous system, central peripheral nervous system. The important thing for me about there's no pain center in the brain is that because the detection of a potentially damaging stimulus is so evolutionary protective in terms of survival, it's really incorporated most of the nervous system. And so that also explains the complexity of pain, and also why we have trouble treating pain, because so many of our normal systems are involved, and the nociceptive system uses pathways that also are functioning in other ways in normal physiological function. So we have many areas of the brain that communicates. We're going to look at that now, and it's really the final. I like to think of all these electrical signals going through our body, synapses, and then we've got this output, which is consciousness and then pain. And these are all the physiological mechanisms that link into our thinking and our emotions, etc., which Ronnie's going to talk about now.
Yeah, I think this is a really useful slide, once again going back to that point that I say I'm a clinical psychologist and people hide under the table at base, but if you can start to help people understand the mechanisms of pain and understanding how the brain makes pain, how it's an output of the brain, they can shift from understanding. We had a woman come through who said that her aha moment in base was when we talked about how pain is in the brain, it's not in your head, but it is in the brain, and starting to help them understand the distinction between that is a really powerful thing. So a simple picture like this within your office helps people to start to connect the neurobiology of pain with the mechanisms and the management approach. And for me, that's critical. If someone says to me that, changing your thinking is helpful for pain, or managing stress is helpful for pain, I kind of want to know why. How does it help my pain? So having a picture like this helps people to understand that actually the frontal lobe is really important for pain. Our thoughts are really important, and you can use the guy with the nail through his foot as a lovely way of explaining that. Ask the patient, what does the patient think that builder was thinking when he saw the nail through his foot? He's got prefrontal cortex activation. He's thinking, oh shit, I've got a nail through my foot. And so that activation of that cognitive, that frontal area of the brain then feeds an emotional reaction within the limbic system within the brain. So that distress system starts going off. You've also got the somatosensory cortex and the motor cortex. So helping people understand why, if we start to target the limbic system, then emotional management can help to get on top of chronic pain. Changing your thinking, it's not just hippy-dippy, lovely ideas from a psychologist, lie on my couch and tell me what you're thinking, but actually changing our thoughts changes the stress reaction, changes the threat value of pain, and through doing that we can start to target those areas of the brain. I was going to say something else.
Well, I'll give you a moment to think.
Go for
just
it.
A little on the side. I met a neurosurgeon who used to do an ablative neurosurgical technique that wiped out your emotions. You couldn't actually isolate them. So it was great. So these people with tremendous pain, they just wiped out the emotional component of pain. So you ask them, how do you feel about your pain now when they woke up? They said, I feel great. Are you still in pain? Yeah, it's terrible. It's like, well, it's not terrible. I still feel the pain, but it's not terrible. They had no emotional content. And then they said, well, you know, how's your wife? I don't care. Have you been to work? I don't care about work. They didn't care about anything else, so it was a disaster. So that shows you the complexity of trying to treat these problems as well.
I've recalled what I wanted to say, and that is that having a picture like this also helps to explain why a simple medication isn't going to cut it when it comes to chronic pain. Because if you give a medication that targets all of these areas of the brain, then actually pretty soon people start describing feeling like a zombie. They're knocked out. And actually you can't have quality of life that way either. So starting to show the complexity of the system also helps to justify why medications are not the answer. It may also help you to justify why putting them on something like amitriptyline or nortriptyline or something that when they Google it, it says it's an antidepressant, and they say, I'm not depressed. You can start to help them understand why those kinds of medications for some people are helpful. And John will talk about meds more later. I'm going to flick through this. This is the same information presented in a different way. Lots of different parts of the brain are activated and important in creating that neurotag or creating that pain experience. I showed you a diagram before that had the trajectory of acute pain. This is the trajectory of chronic pain. And what you'll see is that it isn't a straight line, and it's characterised by these flare-ups that happen over time. These are not acute on chronic. They are part of a chronic pain trajectory, and we spend so long trying to help people in the ED and other parts of the, particularly at secondary care level, understand that actually it's not a new problem. Chronic pain is characterised by these flare-ups. Yep. And sometimes patients know why. You know, they'll boom and then they'll bust and then they'll experience a flare-up. Jess is going to talk more on flare-up management because it's a really important part of chronic pain.
And it's not breakthrough pain, it's not cancer pain, it's not breakthrough pain. So it's a different management strategy.
It's part of a normal trajectory of chronic pain. Okay.
We've really much we've talked about this, but it's really important for people to be able to shift if you're going to treat them. If they keep thinking that there's a peripheral problem and they want to go and have scans and stuff, you've got to protect them while they move on. They've got to come to that point in that cycle of change. And we've pretty much talked about that.
We have.
Yeah, good.
We have.
Yeah, so from the Descartes model, we now know you require a noxious stimulus. So if there's no ongoing noxious stimuli, then think persistent pain. Receptors, we've got very complicated pathways with synapses. So the synapses are areas of control in the body, and that's where lots of modulation happens. And then process through the brain and all the different factors that affect that final output. And then important to also know we have a descending system which can facilitate or inhibit. So it's much more complicated, much more little areas for modulation, and also so that's what makes it so difficult, but also gives us different points of treatment. So we'll briefly run over this. It's important to be truthful to people. We don't know why that person has developed persistent pain. And people find that valuable because they don't get the truth. There's always somebody in the high street that's got the answer, waving another crystal or another manipulation, whatever. We do know that genetics plays a factor. I think it's about 14% sort of determines who develops risk factors for chronic pain. Epigenetics is a really important thing. So in the next slide. So what we do now affects the output of our genetic material. So we used to think that your genes are fixed from mum and dad, and your protein phenotype is fixed. But you can modulate that. Your expression gets modulated by so many things.
This is another useful way of helping patients to understand why is my diet important, why is exercise important, why is mood management important. Once again, giving them some of the basis of the rationale for some of the strategies we might suggest.
So we're going to talk a lot about that today. I don't know how much we're going to talk about diet, but you want there's not a lot of evidence in terms of diet and chronic pain, but there is, and it's becoming more and more researched. The take-home message is probably not to have a pro-inflammatory diet. So like, I advocate like a Mediterranean style diet. Yeah.
Is there any research on food additives, especially the flavour and other enhancers that affect the nervous system?
John might, because he's an occupational specialist, but again, from my take home there is that it's so difficult to research a lot of that stuff. But food additives, and we do know that they're potentially toxic.
The enhancers, they work basically on the neurological system, don't they?
I'm not sure. I just don't know.
Yeah, like MSG and stuff like that. There hasn't really been any, like we don't specifically say avoid MSG, but what we do say is avoid the additives, the processed stuff. Try and eat basically your veggies, that typical Mediterranean style diet. There's probably some evidence for that. The interesting thing about the microbiome, just very briefly, is that they've done experiments mainly in poor little rats and mice, but there's evidence that it may be a factor in visceral pain, and so you can actually do a poo transfer from one poor little mouse to the next and actually transfer a visceral pain syndrome. So that's interesting. Exercise, we have a biological need for exercise, and Lynn's going to talk about that.
Yep.
And then you can, all the chemicals, these are just value-added statements, but there's certainly stuff you want to avoid.
Sorry, just before you jump away, just one, these are environmental factors, and I was thinking about the ACC environment that we live in. It was also interesting on your brain diagram, there was a little zone that said ACC, and I thought that was good. But how much that does drive, in my experience, limited.
In terms of things like secondary gain and some other factors that are very stressful in being within those kinds of systems, actually Jess will touch a little bit on that after, but you're right. There's a whole other dynamic.
There's a whole lot of evidence for perceived injustice and then the problems with that.
And that is stressful as well. And there's financial status, implications to that.
One of your other slides back there sort of implies that chronic pain starts with a nociceptive tissue injury, acute pain, and then it goes into chronic pain, or some people go into chronic pain. Chronic pain comes out de novo without any...
Yeah, absolutely.
Really
sorry.
Good question. Thanks for that.
Yeah.
Chronic primary pain, like someone who develops migraine, it usually doesn't follow a bump on the head. It just develops. It's the way they are genetically, it's the way they're built. So chronic pain can start anywhere in the body, spontaneously. And in older studies, before workers' compensation became common, we look in onset, in BMJ in 1958, onset of low back pain. Most people, they say it just started. Now, in a compensation environment, most people will be able to identify an event.
And the event is, I dropped my pen.
And you're right though, because that slide sort of did imply that, mainly because patients come in with this idea of the starting point, but you're absolutely right, we have lots of patients who say I woke up
and people
and
naturally relate it to something. They've got these little hooks that they hold onto.
We find it's better to start from where they believe it started and then to move them towards this, rather than challenging that so much, because then it's really hard to get them on board with the model. So I think I might touch on that now. When it comes to validation, simply providing education and demonstrating a belief in their pain, and also providing information that chronic pain is a problem in its own right. We often say our service has existed for 30 years. Is that right, John? Almost 30 years?
30 years this year,
We wouldn't have a service if there wasn't such a thing as chronic pain. So really validating it as a problem in its own right is important. Sometimes, though, it doesn't matter how hard you try to validate it, patients hear different things. So we went around some GP practices, Ian and I, and a really well-meaning GP said, I just tell them, good news, there's nothing wrong. And we could see where she was coming from. She was coming from a good place. She was trying to say there's nothing going to kill you, there's nothing really dangerous. But of course, if you're the patient sitting there with chronic pain, you're thinking, what do you mean there's nothing wrong? You try living with the chronic pain. So it's really important to just be aware of the language that you use. So patients hear things like, you have pain, but it doesn't matter. Or you have pain, you just need to push through it and get on. So that's that idea that you can't hurt yourself, you can still do things with pain, but that idea that you just need to push through it can be detrimental if patients hear it the wrong way. So we find it's more helpful to start from where the patient is at, find out what that means to them, what do they think is going on in their body, and then move from that towards helping them understand chronic pain within the nervous system and some of that neurobiology that we've been talking about today.
Yeah, and people often say, when you give them your little metaphors and you're trying to move them on, and so people will often say, you mean I've just got to get on with it? And I say, no, you've got to learn all the latest techniques that research has shown so that you're not disabled by this, you're not fear avoidant, you can engage in work. So you've got to get them engaged into actually using those strategies.
Here are some things to try not to do and some things that are helpful. So try not to discount the pain and the related stress. Try not to focus so much on the end pathology or even pain intensity scores. We don't ask patients to rate their pain so much. It is possibly more useful in primary care, to be honest, when you're trying to get a sense in the initial phases of where a person's pain is at. But once you know someone's had chronic pain for a number of years, getting them to focus on pain scores actually amplifies their focus on pain and gives it an even bigger entity in their life.
Pain diaries.
So pain diaries, I think we do suggest later that a pain diary can be helpful in primary care, but just be wary if a patient's had pain for 20 years, then a pain diary is possibly not what you want to get them doing. Be really aware of when you're inadvertently reinforcing pain or pain behaviours. Now, the thing about being a healthcare professional is that we're really caring, thoughtful people, and we want to offer empathy and kind of express that understanding. And so we find ourselves going, yeah, and even nodding when we kind of don't even realise it. And so if the patient's saying something like, I'll never be able to go back to work, I just know that that's impossible, and we're going, then it might come across that we're agreeing with them that they'll never be able to work. So just be aware of those behaviours that you're trying to validate, but it might inadvertently be keeping them stuck. The things that can be useful are being aware of biases. I'm going to talk about that a lot more later. When it comes to chronic pain, there's a lot of stigma and biases that can exist. Encourage active engagement in valued activities. So try to take the focus to the things that matter to the person, and it might only be one or two things that we're getting them back into doing. Listen to the pain-related distress. That's more helpful than pain scores. So try and focus more on the effect of the pain, the meaning of the pain within their life, rather than the quality of the pain or the pain scores, if that makes sense. And then this last part we've already said, so validating that they do have chronic pain, and it's really hard to live with chronic pain, and it's something that exists and is a real problem within New Zealand, but also internationally. But we also know that there are people that live with chronic pain well, so helping them to see that actually they're not doomed with that diagnosis, but how do we move them towards the bottom of that pyramid, if you like.
Are they eligible for sickness benefit of the chronic pain? Is it considered, does that put them in the eligible?
It does, a lot of low back pain.
These are some ideas from actually a recent conference we just all attended in Australia, the Australian New Zealand Pain Society Conference scientific meeting. One of the speakers talked a lot on validation skills, and so just that idea that actually they trained people up and how to offer more validating statements and validation within the consultation. So things like minimal encourages, they are useful in the right place. It's just being aware of when you offer them. Reflective listening, so paraphrasing back what the patient has said. You don't have to agree, but just letting them know that you've heard where they are and how they're stuck. putting yourself where the patient is and how they might be feeling. I guess framing their behaviours in the context of their situation or their history. So for example, someone who's really grumpy and snapping at everyone in their life, helping them to see that actually no wonder you're snappy, no wonder you're irritable, you're getting 1 hour sleep a night. And so helping to say that actually, let's not focus so much on the irritability, but let's go back to the sleep and focus on a sleep diary and things that we can do to help that part that might be driving both the pain problem and also the mood problem. Communicating, understanding, treating patients as valid and capable, and always involving partners and parents. We find that if you don't deliver the education to the system, then you can do great education and then they go home to try and get back into, let's say, mowing the lawn because it's important to that person. But then if their partner then goes out and mows the lawn or finishes it off or tells them to stop, then actually it undermines all of the education you've done. Or parents, if you've got a child with chronic pain. So working with that whole system is really important.